sympathetic. We have a part of our brain that's in parasympathetic, which is rest, digest, and kill the pests. And when we come into the relaxed part of our brain, many things are possible that aren't possible when we're in that catastrophizing thing that many of us have like been so exhausted we undergo catastrophizing just to keep us going. So that was nice. The first talk that we talked about setting the train so that we could maximize our nutrition, our hydration, our sleep, our minds, our connections to our highest purpose, and get ourselves ready to heal. Last time, Megan talked about some of the chemotherapies that can help and some traditional Chinese acupuncture ways of thinking about wellness. We're taking quite a turn this time about chemicals that we can put in our bodies that can open up healing pathways. And they don't just kill bugs, but they work in a number of ways, like almost everything. But it's I don't believe that there's one answer for everyone, but certainly dysolfram and methylene blue have been very helpful to many patients in my practice. And I'm really grateful Laurie Radovsky stepped up. I asked all of the practitioners in our, how many is in our group? 80. And I got one person in our physician clinician group to want to speak. And, you know, thank goodness it was Laurie. Laurie, go ahead.
Thank you. Well, thanks so much. I'm going to share my screen in just a minute because I have this fancy PowerPoint that I had lots of fun creating. But before I get started, to Karen Vrchota. Karen, you were the person who a little more than 15 years ago said to me, 60% of what we call chronic fatigue syndrome in Minnesota is actually Lyme disease. And that sent me right down the rabbit hole of doing this work. And so you've been my mentor all this time. I continue to learn from you, and I really treasure our friendship, and I'm just so happy that you're here still working, and I love you.
Well, thank you so much. Thank you.
Okay, so I'm going to share my screen and going to talk about, let's see, I want to try to, whoops, there we go, view slideshow. Okay, great. So I think we're set here. So that, you know, with doing such a broad topic, I run the risk of overwhelming people who don't know anything about dysulfiram and methylene blue and boring the people who know about it. And, you know, many of you are on it and could probably tell me a lot about it. But I'm going to kind of try to do the middle path. And I'm sure that when we get to the question part, and this is not a super long presentation, we'll have plenty of time for answering questions. So the first question is, why do we need other treatments? And the reason is because antibiotics don't always work to eradicate Lyme disease. We all know people who have been on antibiotics for years, and they either don't get better or they get better and then they relapse. And so we really need to look at alternative therapies to overcome the challenges of antibiotics. So why don't antibiotics work? Well, antibiotics are kind of like in Star Wars where they're going to blow up the Death Star. And you know how they have to, like, they have one spot that they hit, and if they miss it, they don't blow up the Death Star. And that's kind of the way that antibiotics work. They have one very specific way that they kill specific bacteria. Now, remember, Lyme disease has 3 different ways that it can be in our body. And you know, one antibiotic will kill one form of it, but not another. One of the reasons why that it's a challenge is because there are different ways that the antibiotic or that antibiotics can intervene with killing bacteria. So here we have the way that bacteria grow. They double, and then they kind of just hang out, and then eventually they die. So the challenge is a lot of antibiotics will work in this doubling time, like they interfere with the process of the cells dividing. But if the bacteria are just kind of hanging out here, the antibiotics are not going to be helpful at all. The other reason why it's a challenge is there are cyst forms. When bacteria get threatened, at least some of them, like Borrelia, they can create a cyst form, which is basically like an armadillo curling up on itself. And once the antibiotics are gone, then it can uncurl into the spirochete form. And then if that wasn't enough, there's biofilms. And all of you have probably heard of biofilms before. They're the slimy mass of fallout shelter that bacteria can hide in, and that our immune system and the antibiotics can't get into. The other thing is that there are some drawbacks to antibiotics, which we all know. Allergic reactions, destruction of our microbiome, antibiotic resistance. So for many reasons, we want to look at alternatives. So one of the ways that we have done that is to basically take everything we can think of off the shelf and drip it on Lyme bacteria and see if it kills them. So that's called high throughput testing. And in this one study, which is probably like the basis of everything that we've done with dysolfram since then, there were over 4,000 different things that were tested, and about 150 of them were found to be helpful in killing Borrelia, but dysolfram was the most effective. So what the heck is dysolfram? So it was actually created in the 19th century. It was used at one point to treat scabies, so we know that it has some antimicrobial effects. It's been currently used since the 1940s or 50s because of one of its side effects. It basically blocks the metabolism of alcohol in an intermediary step, which is very toxic. And so if somebody drinks and they have had dysolfram in their system, it makes them horribly ill. So someone who is trying to avoid drinking can take it to kind of help keep them from relapsing. And in that context, it's been used actually in very high doses, much higher than the doses that we're talking about using. So how does it work? Who the heck knows? I'll remind you that there are a lot of things in medicine that we don't know how they work. Tylenol, we don't know why Tylenol works the way that it does. And obviously there's a lot of research going in to try to figure out how it works, but all we know is that it does work. And what it appears to do in particular is a couple of different things. One is that it kills Borrelia, Lyme. It also kills Babesia, which is one of the other major co-infections that we see. It kills the cyst form of Borrelia. That's the one where it curls up on itself and it becomes dormant. And it appears to disrupt biofilms. So unfortunately, we don't have a trifecta. It doesn't help with killing Bartonella, which is the other main co-infection, but it does break up the biofilms, which makes it a little bit easier to eradicate. So we've only been using disulfiram for less than 10 years, and there's not a lot of data that's been published yet, but the data that has been published has been very positive. Ken Ligner published a study of 71 patients, and at least a third of them had what he called enduring remission, which is they basically got better. Now, there's certainly a lot of side effects: fatigue, psychiatric symptoms, neuropathy, and liver inflammation. And what he found was the higher the dose, the higher the side effects. Also, the higher the dose, the more likely the patient was to get better. So when should we be using disulfiram? It certainly is not what we would call a first-line drug. It has a lot of side effects. It's still relatively experimental compared to the history that we have of using, conventional antibiotics. But it certainly can be used if people are not responding to antibiotics or if they relapse. And it's especially useful in situations where people can't use antibiotics. Many of you probably know about an infection called C. difficile colitis. It's a very persistent bacterial infection of the gut that happens when people are on long-term antibiotics. And the concern is that it can hide out in the gut. And if you take antibiotics later, it can come out in hiding. So it still is considered, I think, a very useful and important way to treat Lyme disease that has not responded to the simple treatments. This is a very powerful drug, and it needs to get started at a very low dose. It comes in 250 milligram pills. You can cut the pills in quarters and take 1/4 of a pill every 3 days. And it can only be increased every 14 days because it has a very long half-life. The target dose is based on weight, so you can imagine how long it's going to take for somebody to get up to their target dose if they're going up by 62.5 milligrams every 14 days. Not all patients can tolerate what we like to call their target dose. Often patients end up having to stick with a lower dose. And we think that if they use a lower dose for a longer period of time, it can still be quite effective. So I just really want to reiterate that, that this is not cookbook medicine. You really have to individualize treatment for patients, even more so than when you're talking about using herbs or conventional antibiotics. It really needs to be increased slowly. If patients get impatient and use it and increase the dose more quickly, they can really end up being pretty darn sick. And some people can't even tolerate the 1/4 of a pill, and we need to end up using compounded forms, starting with 20 milligrams or even 10 milligrams. And if somebody continues to have problems, they really need to decrease the dose. I think all of us who prescribe dysolfram require an informed consent. Patients have to be very aware of the fact that they cannot use any kind of source of alcohol. That includes hand sanitizer. It includes kombucha. Dr. Vrchota, I think you had a patient who dipped a French fry in ketchup and reacted to that because there's vinegar in ketchup. At the other end of the spectrum, I had a patient who literally could drink a glass of wine and it didn't bother him. So different people have, very variable reactions. And I tell people that they need to be cautious and really just kind of listen to their body. They also need to have labs checked regularly because it can cause liver inflammation, and we need to check the liver labs on a regular basis. And also, of course, just watching for other side effects, which include neuropathy and actually psychosis at times. And it's actually pretty scary if somebody starts to have mental status changes on this drug. And because it's in their system for a while, you can't just stop it and have them get back to normal. So bottom line is, it's a drug that can be very effective, but also needs to be very carefully monitored. Now, I've had patients that have been prescribed disulfiram and they call me back a couple days later and they say, I'm afraid to use it. I've been on all of the message boards and the Facebook groups, and they say that it makes you horribly sick and I can't afford not to work. So is it a myth or a fact? Disulfiram makes you very sick. So it is true in the sense that if disulfiram is not dosed appropriately, it can make people extremely ill. But if a Herxheimer reaction lasts for more than a couple days, I think it's important to recognize that your body's just not tolerating that dose and it needs to get cut back. And the other thing really to emphasize is 2 weeks is the fastest that you can increase the dose, that people really need to listen to their bodies. I use the analogy of being at the beach and getting hit by a wave. And the wave kind of destabilizes you, but then you get your footing back and then another wave comes and it destabilizes you and you get your footing back. But if two waves come in rapid succession, then you get knocked over. And that's what happens if you increase the dose too quickly. The other myth I've heard is that disulfram treatment is dangerous. And again, there is actually some truth to it. It absolutely must be monitored and used appropriately. And that's why most of us who use it really insist on patients having regular lab work, regular visits, making sure that you're actually doing okay. And the biggest issues that I see with it, besides people who are exquisitely sensitive, are just people who are kind of frustrated and they're doing in one dose. And so they're like, well, I'm just going to go up to the next dose a little too fast. My experience is that I've had patients who do one dose and do fine, increase the dose, do fine, increase the dose, do fine. And there's kind of a threshold. And the next time that they increase the dose, it does make them horribly sick. So you really have to be careful and go as slowly as your body allows you to go. So that is disulfram. So we're going to take a little break. This is San Diego. I was thinking when I first signed up for this that this would be a really pleasant thing to look at because there would be, 6 feet of snow and lots of ice outside, but it actually looks more like St. Paul than it does like some other place. Okay, methylene blue. So methylene blue was discovered kind of the same way that disulfram was. This was a different study that looked at specifically drugs that were helpful for that persister, the stationary phase, the time when the bacteria are not doubling. And they looked at multiple different things and found that, among others, that methylene blue was particularly helpful for that. So what the heck is methylene blue? It is actually a blue dye. It was created to dye when people are looking at a microscope and dyeing cells. They actually found that when they used it to look at malaria, it would kill the malaria. So it has known antimicrobial effects. It's actually also used, interestingly, in a compound for recurrent bladder infections because it gets excreted through the bladder. And the main use of it these days is to treat a condition called methemoglobinemia, where the oxygen is not being able to get to the red blood cells. And the reason that it does is because of another benefit it has, which is donating electrons, and it actually can be used to help generate energy on a cellular level in the mitochondria. Okay, so how does it work? Again, who the heck knows? What's really fascinating about these things is that we're probably going to find that they have more than one way that they are impacting the things that we are trying to eliminate. But the things that we do know are, as I said, it kills the stationary, the non-doubling phase, which I'm just going to show you again. So it's this stationary phase where the bacteria are just kind of hanging out. It also, and it does it not just for Borrelia, but also for Bartonella. And that's important because Bartonella is probably one of the most frustrating infections that we have. It also improves mitochondrial function, and so it can make people feel physically better above and beyond its effects on the infection. And it also impedes the breakdown of acetylcholine. So it's not just improving fatigue, but it actually can improve your brain function. And on top of that, it can help improve depression. So when do we use methylene blue? So obviously it can be a great treatment for Bartonella. Again, it's not really used that much as a first-line drug, although maybe it should be too, because it doesn't have the drawbacks of of regular antibiotics. And I think at some point in the future, as we do more and more research, it may end up being very helpful. And I've actually started using it for patients at the lower doses, just to kind of help with mitochondrial function and see if they can feel better. So if it's that great, there must be some drawbacks. And of course, there are. Whoops. Oh yeah, okay. So I'll just talk about the dosing first. Sorry about that. So as with the disulfiram, I think it's really important to start at a low dose. Sometimes people will have very strong flares of their symptoms, Herxheimer reactions. And when you're using a low dose, you can actually get a pharmaceutical grade product over the counter. As you increase the dose, it doesn't make sense to use the over the counter products. You really do need a higher amount. And so at that point, I will start having it compounded rather than just having people buy it over the counter. I do think it's important to tell people that even though they can get it over the counter, that it's really not something to just kind of like throw into the mix yourself. If you're working with a Lyme clinician, it's really important to ask them where they see it fitting into your treatment strategy. Now, one of the things that's really interesting about using methylene blue is something that I actually, oh, and I'm sorry, there's the methylene blue caution. So there is an enzyme called G6PD, and if it's genetically absent, you can't use methylene blue. So it's just a blood test. It can be done at a regular clinic, but it has to be done before you start methylene blue. There is a risk of something called serotonin syndrome, where you have too much serotonin in your system. And so if somebody is on an SSRI, Prozac, fluoxetine, Zoloft, sertraline, any of those, you have to kind of decide how high is the dose and how much of a risk is there of serotonin syndrome. I have had a couple of people who have had like really excruciating bladder pain. I don't know if it's a Herxheimer reaction, as the bacteria that are hiding in the bladder wall are treated. We know that Bartonella lives there. And then the other kind of weird side effect is it makes everything that it comes in contact with blue. So if you're taking a liquid, it will turn your mouth blue. If you're peeing it out, it will turn your toilet bowl blue, make your urine blue. It doesn't stain the toilet bowl permanently, but it is kind of like a weird thing. And then I didn't have enough information about using methylene blue and red light therapy, which I know Dr. Vrchota has done. And so I'm actually going to turn the presentation over to you and let you talk about that particular use of methylene blue.
Thanks, Laurie. That was great. I just have a couple of things to add back on to what you said. The dosage that I've used is 0.5 to 4 milligrams per kilogram. So it's based on body weight. And the study showing that it can cause serotonergic syndrome was in people that they were using 10 milligrams per kilogram. There's been no case reports of people on lower doses having adverse effects from MAO inhibitors or SSRIs. So I think that's somewhat reassuring.
Mm-hmm.
And that methylene blue acts as a proton donor. So like that's how we make ATP. That's like the batteries of our cell make this ATP. And the mito red light, people always want to know what one I use. This is the most affordable and dependable. Mito red light is also a proton donor. And I stick it under my shirt and use it for 5 minutes on my chest, and then 5 minutes on the abdomen, 5 minutes on the back of the chest, and then 5 minutes on the kidneys. a lot of people with Bartonella have Bartonella stuck in the lymph nodes of the legs. So I also have those nodules on the extensive surfaces of the long bones. So I will, when I have time once a week, go ahead and treat the legs. But then it's 5, 10, 15, 20, 25, 30, 35, 40. It gets up to like an hour a day. The half-life of methylene blue is 12 hours. So if you want to use the mito red light, which is 660 nanohertz, I think that's what it is. There's 660 and 980, but you want the one with 660. And there's a couple of places that sell it, but Mito Red, I have no investment in the company. My patients have gotten it and they've been satisfied. If something didn't work, they took the product back. So I thought, that was helpful. I think it's helpful on its own to increase mitochondrial function. The research on methylene blue, I saw several hundred articles. It's used for sepsis, people that are dying of bacterial infections in their blood in the hospital. It's used on wound care. It's used in binding to the tau bodies and Alzheimer's. And there's another protein in Parkinson's. I can't remember it. Maybe, Laurie, you can. But it binds to those proteins. So there's some pretty good studies showing that in low doses, it's used in many different neurocognitive conditions. One thing that I was kind of cautious about is it's used in a condition called pruritus ani, or itchy anus, that nobody really understands what causes it. I've tried to treat it for a long time, and methylene blue is a successful treatment for that because it decreases inflammation and increases serotonin and norepinephrine. But the other thing it did was it decreased the nerve endings. And I thought, what? Decrease the nerve endings? So I looked into the research behind that, and I don't know if I want to take something that decreases nerve endings to decrease pain. It seems like I'd like nerve endings to grow back. Methylene blue is widely available in many contaminated forms where people say it's pharmaceutical grade, but it's not. Is there a pharmacy in the Twin Cities that people can walk in and get pharmaceutical grade methylene blue that you know of?
I don't. And yeah, it would be worth talking to our compounding pharmacy friends, because if they can get it to create the compounded forms, they can probably get it in, dispense it in a powder or a liquid form at a lower dose, and know that you're getting a USP pharmaceutical grade.
Okay. So a friend of mine, Scott Forsgren, who's known as the Better Health Guy, that I've known for, I think since 2003, we've gone out to dinner, and he's somebody who's been very sick and really had to find his own way home. And he runs a website called the Better Health Guy, and he interviews different practitioners. And so episode 166, if anybody wants to find out more about methylene blue, he interviews a chiropractor who has a product called Mitozen. I think it's Mitozen. And there's a link if you go to his website where you get a discount, but I'm not invested in it, but it is pharmaceutical grade, and Scott has checked it out, and they come in 40 milligrams and 180 milligram little bars that you can cut into quarters and put them way back in your mouth and swallow them. You don't want them to be in your mouth. You don't want them to dissolve in your mouth. Your mouth will all turn dark blue. So I think that would be my safest bet for a pharmaceutical grade product. He does have other things in that product that he talked about the benefit in that webinar. But I haven't found pure methylene blue and pharmaceutical grade that's available over the counter from a distributor that I can count on. As far as I know, there's only 2 compounding pharmacies making methylene blue, PD Labs in Texas and InfuServe America in Florida. And Dennis from Hopkinton Labs used to have the best methylene blue. That's the product I used, and it was great. And he gave his formula to the people in PD Labs in Texas and went down and made sure they were making it like he made it. So I've worked with those 2 pharmacies for 10 years or more.
Yeah. So cool. Anything else about the red light therapy? And it's like, how is it that the red light therapy and the methylene blue augment each other's, or the red light therapy augments the effects of the methylene blue?
Well, when you go on to the research studies and I was going to do, I thought I was going to do all the methylene blue, so I had a PowerPoint. Let me see if I can share screen and find that quickly.
Mm-hmm. While you're looking at that, I'm just looking at the comments, and somebody had a question about MAOI, which is monoamine oxidase inhibitors, and that is another category of medications that can cause the serotonergic syndrome. Methylene blue is not an MAO inhibitor, as far as I know. But if you are on an MAO inhibitor, you should be very careful about using methylene blue and be cautious on how you're ramping it up and watch for serotonergic. So I'm very happy to hear that the concerns about serotonin syndrome were at much higher doses than we would probably use.
Yeah, the methylene blue increases serotonin because it increases mitochondrial function. So when your batteries are more charged, you make more serotonin and norepinephrine. And if you had something that stopped you from breaking it down, then theoretically you could see how it would lead to possibly serotonin syndrome, but not at that range 0.4 to 4 milligrams per kilogram.
Yeah.
There's a question about, did you see the question about disulfram, Laurie?
I haven't gotten down that far. I do actually want to just highlight, Anna, you said if you have more food in your stomach, you're less likely to have nausea with the methylene blue. And then somebody else said, if you're taking it by liquid, mix powdered vitamin C with it, and it will turn clear and it will not look blue and stain your teeth. So yes, so there was a question about disulfram doesn't really harm the gut microbiome. Absolutely, it's one of its great benefits is that because it's not antibacterial in the sense that that antibiotics are, that it doesn't destroy your gut microbiome. And I will generally, if somebody's just on disulfram and not on antibiotics, I have not told them that they need to be on high dose probiotics.
Could I ask about somebody who's looking for more help and they're not seeing you or somebody that you know, could they request that their Lyme provider reach out to you if they want to explore disulfram and see if that might be the piece that helps them move further?
Yeah, absolutely. And I think, one of the things, some of you who are on this call already know that I'm hoping to be able to retire in the next 3-4 years, something like that. And Dr. Vrchota is already retired, and there's like a desperate need for more people treating Lyme patients. And what I'm going to be exploring is ways to create like a consultation service, so that if somebody's not as experienced with treating Lyme, they can use my services to kind of learn about it and have patients, run patients by me. And yeah, I mean, and in the meantime, I'm more than happy to have anybody reach out who has any questions about treating with disulfram. Happy to give them advice about how to treat their patients.
Thank you.
I think to find the Kenneth Ligner, Liegner, paper online is like the first thing that he did a series of patients. He did an initial series and then a longer term series. He's had 2 papers on disulfram and Lyme. I think they're pretty easy to find. So that would be something you could go into your doctor with. And then they'll be able to come to this website and see this talk and find the dose and, find the precautions. I'd like to say I had personal experience with disulfram. I was on it for 57 days and had long-term remission from it, but I got a little goofy. Goofy in what way? I felt like my gate receptors were open, like colors were brighter, sounds were sweeter. All my life was better. I had so much energy that I couldn't imagine feeling any better than I did in that moment. I knew I was off, but I wasn't making misjudgments. I just thought this is so great. Like if people don't have to take antibiotics, I was very excited about it. Some of you are nodding. I see that grin. Gail, did you see me during that time? I was really excited about it. And I'm not excited about it now because I went to have a crown placed, and the glue that they use to glue the crown on has a high dose of alcohol in it. And my liver function tests that are supposed to be in the 40 to 80 range went up to 2,000. It was like I could have died from that. I didn't know that the glue on a crown was something to be concerned about. I didn't know that the mustard and the vinegar and mustard was enough to be concerned about, or hand lotions or any of those things. I have a family history of alcoholism. I am myself very sensitive to alcohol. So people with that history, that you have a first degree relative with alcoholism, that you have a deficiency in breaking down alcohol dehydrogenase, and so you're more susceptible to the side effects of disulfram.
I did just put the link to one of Dr. Ligner's articles, and then Anna, did you put another one? Yeah.
Some people say, can you take disulfram and methylene blue at the same time? And I certainly gave those at the same time. And people did fine with them. So they are metabolized differently. So they're not going to make each other not get metabolized. Methylene blue is absorbed through the stomach, and so it doesn't go in the small intestine. And so it doesn't disrupt the intestinal biome either.
Yeah, I've also used regular antibiotics and disulfram, especially as if somebody's basically relapses every time they go off of antibiotics, I'll keep them on antibiotics as we're increasing the dose of disulfram, so there's no real contraindication against using them. The other thing is that if somebody has Bartonella, the antibiotics that treat Bartonella are different than the ones that treat Lyme, and disulfram doesn't get Bartonella as much, and so I will often use those together if needed.
I have a personal love for methylene blue. So I think that's what really got me cleared of Bartonella, which was a 10-year haul, which, as anyone knows who's had it, is not fun.
Do you remember, Anna, what dose and what length of time it took?
I want to say 2 years. I stopped for a while and my symptoms started rising again. I started with 50 milligrams and I have a red light, but I have near and far infrared and it is bigger. I can't remember. I'll look at the type, but it's also sealed so there's no EMFs. And I would get in front of the red light within the first hour of taking us. Pretty good because I habit stacked my meditation. So I could do them both at the same time. Otherwise, I just didn't really have the time. But I spent, I think, 3 years. Laurie, you might be able to help me more with that. But I am still currently taking it because I feel better on a 50 milligram dose. But my top dose was 100 for about 2 years. It's not cheap, but I just don't try not to look at what I pay when I get my bottle.
Is it about $3.50 a day? Is it in that
No,
range?
well, no, 7 a day if you're on 2. Not that I'm counting.
$7 a day.
Correct, just for the methylene blue.
I mean,
It's
I
well,
think
you know what? I have a life.
Well-
I have energy. To me, it's money well spent.
Yeah, thank you. That's very helpful. The more people that we hear from. And have you done it with and without the red light and compared like how it works?
Well, you know, I don't have anything clinical. I know that I have, I feel as though I have more adrenal resilience, and I don't even know how I would know that, but I feel that I have more core energy rather than something that's going to be up and down all over the day. It feels very steady for me when I use the red light with the methylene blue. And I've gotten it about 4 days a week instead of 7. I was really hitting it hard when I was, very diligent, and I'm sloppier, I'm busier. But for me, that feels like the maintenance dose, and I am not as energetic, or it feels like there's a mood piece in there too, of a calmness when I don't do the red light at all.
Yeah, I mean, there's huge science on photobioregulation, like what the light does to increase mitochondrial function in individuals and how it works anti-aging on skin, hair. My friend Maureen McShane said that her friend got a helmet from Costco with the near infrared, and their hair grew back. A lot of people have lost hair with hormonal changes with these diseases. So, the doctor that was at the betterhealth.com, he's using an intranasal. So like it gets the light right into the brain with intranasal. So that's like the Vilite. Have you heard of the Vilite? Is being used in Parkinson's and Alzheimer's and mild cognitive dysfunction. But I think you could also use that with methylene blue.
So can I just say about the red light, if anyone feels like, oh, how could I put one more thing into my day? I'm just going to be completely honest. The only thing that really gets me there first is vanity, because I just put my head down for a while and I do the top of my head for my hair, for my scalp. And then I have, it's like a 3 to 5 inches for your face, and I do 3 to 4 minutes of that, and then I get to business. So that's what gets me there.
It does. It helps the collagen rebuild itself, and many clinicians that work with aesthetics people go in and just have the light put on their face. You have eye protection when you do that, Anna?
Oh yes, yeah. There's like dark. They have glasses that comes with the machine for sure.
Because I don't think the light's supposed to shine in your eyes.
No, it can shine through the goggles, or you could be 3 feet away, and do some dental, your gums and whatnot.
I'm curious if anybody else would like to come forward with their experience with dysolfram and or methylene blue. Okay. I mean, it's a recorded thing, so people might want privacy and not
Yeah.
be willing to do that. But
There are a couple more questions. Someone's asking, do you ever combine dapsone with disulfiram? My personal feeling, and I know that Dr. Horowitz is like super into dapsone and double dapsone. I find the dapsone protocols to be very cumbersome, very expensive. I have not had good luck with them. I've had a couple patients who have wanted to try them, and I've kind of gone along with it and prescribed it. But I'm not a big fan of dapsone, so I haven't combined it with disulfiram, and I'm not sure. I haven't heard anybody say you shouldn't, but I also haven't heard anybody say it's okay.
yeah, I sure wouldn't do it because the side effects for both of them are just so
Mhm.
so bad.
Mhm. Yeah. And someone else is saying my friend who had long haul COVID, red light saved his life. So thanks for that, Tyann. And then Sue was on disulfiram twice, was good for about a month each time, but then symptoms came back, manic at the end, also neuropathy is an issue. So this is actually bringing up a couple of really good points. You know, we think about infections as being like a cold. You get a cold, your immune system fights it off, it's eliminated from your body. And what we believe, especially with the tick-borne illnesses, is that they have the potential to not be eradicated, but to remain in our systems in a dormant phase, just kind of waiting for their chance to come back out of hiding. And so when someone, what we call going into remission, when somebody goes into remission with tick-borne illness, there's no guarantee that they're going to stay there. But what I always do is I try to figure out, like, okay, so what triggered their immune system to falter? What created the environment that the infection could come back out of hiding? And one of the things that we haven't talked about yet on this in this session is mold. That mold is powerfully immunosuppressive. Often when I've had patients that have gotten better and then relapsed or plateaued or do okay on antibiotics and relapse as soon as you go off of them, I'm looking at what it is that might have created the environment to let the Lyme back out of jail. And so just continuously, you know, giving people rounds of antibiotics or rounds of disulfiram may be the only way that they can function, but I think it's important to try to figure out why is it that their immune system is not able to overcome the infection. Do you have anything to say about that, Karen?
No, well, my friend Maureen McShane, we've like been down this road together for 20 years, and she said that sometimes people will bring friends to her clinic, but that they'll have told them about the diet, the anti-inflammatory diet, where you have like a lot of colorful vegetables, and some people lean chicken and fish, and some people beans and plant-based protein. And she said people would be 40% better already just having changed their diet.
Yeah.
And getting off caffeine and gluten and dairy. So like people that are on, I mean, you're tired. So like you want to take caffeine and then your sleep doesn't go deep. And when your sleep doesn't go deep, your melatonin doesn't go high. When your melatonin doesn't go high, you can't fight infections. And it's like a endless thing. If the lifestyle stuff is, I don't feel like going off caffeine. I don't care if I sleep or not. You know, I could never get anywhere without lifestyle changes. So I think those things are important.
Yeah, absolutely.
I had a question. I didn't want to interrupt if it's a good time. I know I brought this to this group before, but I've been being treated now for mold and for Bartonella, and I developed a really bad discoid eczema all over my legs. I had some spots on my arms, And at first thought it was a reaction to the methylene blue, but Dr. Vrchota, you mentioned that can go into your legs, Bartonella can, and was it maybe just targeting something at a deeper layer than I've had before? I finally have the eczema, I think, under control, and the antihistamines really helped. But it's not just going away. It's, it kind of flares, and I'm just wondering if I'm going to have these spots forever. But when I researched discoid, and they're definitely in circles, when I researched discoid eczema, it just says it can come with infections, not in
Well,
any specific way.
Strep is an infection that can be a trigger for discoid eczema.
Strep? Okay.
Strep. That's not covered by a lot of antibiotics that we use for Bartonella.
Okay.
So my experience is the biocidin products are pretty helpful. The throat spray and the liposomal formulas that I have people swish with that after they brush their teeth at night. When we all have strep on our gums, and when we brush our teeth, the strep goes into our blood and can keep triggering things like pandas, discoid eczema. And I don't know, just addressing strep can be, but then, the other thing is what else can you do to make your body more healthy? Is there, other things that if you're doing everything else to help yourself sleep and stay hydrated and
yeah, I think I really am.
Eat a healthy diet. I don't know. I think that's been pretty helpful for my patients with discoid eczema.
Yeah, or any special herbs that help assist with skin cleansing or that blood vessel cleansing, because maybe it's killing stuff and it's just not able to get it out of my body. I don't know. Thanks for the advice. I appreciate it.
There's another question. How long do people typically need to take dysolfram? Well, first of all, you need to ramp it up. And so depending on what your target dose is, that's going to take 2 or 3 months just to get up to the dose that you want to be on. I have been keeping people on it for 3 to 4 months at the target dose. And then when you stop it, you don't have to go as slowly as when you start it, but you don't want to just stop it abruptly, that people will report mood changes if they don't taper off of it over the course of a month or so.
And so really they're looking at 6 to 9 months of taking it, right, Laurie? But that might take them 6 months to get up to full dose, and then 3 months at the full dose, and then go down. And Ken Ligner presented that a couple of the people in his first report on 4 patients stayed well, and then 2 people that got completely well got sick again, and that they had another recovery with a repeated course. And at the time, he was just starting the same dose that we are taught as practitioners is the dose for treating people with chronic substance use disorder due to alcohol. 250 milligrams for 3 days, and then 500 milligrams is what we learned, and what I used in clinics that treated substance use disorders. But I didn't have too many patients that tolerated those doses.
And if somebody's options are to go on and off of antibiotics or disulfiram in order to have a good quality of life, every time they go off of them, if they relapse, then that may be what they need to do while you're exploring why it is that their immune system is not strong enough. Do they have some kind of immune deficiency? Is it something like, mold toxicity?
That's a good point, Laurie, because I would say after I took disulfiram, I was cured. Like I could do everything in life I wanted to do until I had a huge mold exposure. And then all of my tests to Babesia, Bartonella, and Borrelia came up positive after they'd been negative for 2 years. And I got symptoms again. So I don't know how that works. Like, where were they? What were they doing? And how could they get active with mold? But it seemed to be what happened.
Yeah. Yeah. I think that there's this incredible synergy between mold and Lyme. And I've had patients that have been, living in a moldy environment for decades and doing fine, and they get infected with tick-borne illness. And then they get better from the tick-borne illness, but the mold toxicity is horrendous. And the other way around too. People who were probably bitten and have Lyme disease or other tick-borne illness for years, and they move into a moldy house and all of a sudden they get sick. So there's a real synergy between those two bad actors. So.
And people can certainly take binders while they're on dysolfram and methylene blue.
Mm-hmm.
I like the Quicksilver push catch, but you can't take the liquid part of that. You can't take the Dr. Shady's liver sauce because it's got alcohol in it. You can't take any tinctures. You can't take any of the Cowden. You can't take any of the Gemmos. You can't take Byron White. The only thing you could take for herbs really are the capsules, right?
Mm-hmm.
I mean, the glycerin should be okay, but some people don't tolerate glycerin while they're on disulfiram either.
There's a question about which series of the Mito light box do you recommend?
Well, it's a budget thing. I just have the little one because I'm of the age that I don't want a bunch of junk around my house. I don't want to have a big light box. And some people get a light box in back of them and a light box in front of them, but I don't mind sitting for an hour in a day and having it like right in contact with my skin. So this is like perfectly fine. And it's much more affordable. I think it's in the $200 range, or, not $1,000. But Anna said that she has the big ones that she stands in front of and does her meditation. And she likes it because it's also good for the skin. It does anti-aging on the skin and the hair. Anna, do you want to comment? You're on mute still.
So I have not the large one, which would be a time saver. Mine was 550, and you could get a double pane, so you could do front and back, top and bottom at the same time. I just didn't feel that another 500 was worth. I mean, my time was okay. I don't mind sitting in front of it and doing other things.
But people shop for hours and hours, and I think, like, buy the little one and see how it works. Like, see if you like it. Certainly, it is great in Minnesota in the winter. I'm not putting it on when it's 90 degrees outside.
I like doing red light in the summer. Winter's really tough for me to strip down. You put it right on your skin, and I have to put a heater around. I've got to sort of get myself suited up and then sit in front of it. But I'm a spring summer girl for red light myself.
Okay. So different experiences. The one from Mito Red does not burn you if you put it in contact with your skin. You don't have to be 2 to 3 inches away from it.
There's another question about the difference between near infrared, far infrared, and red light.
So near infrared has the mitochondrial activity, so the energizing activity. And far infrared is used, to the best of my knowledge, mostly for sauna. That it makes you sweat. It warms you up. It's got warming rays. And so some people use combinations of those. But the far infrared, you can just go in there without goggles on and you're fine. The near infrared, you need to protect your eyes.
And someone said, I used red light on my mouth once rather than have a root canal. It seemed to get rid of the infection. So
There's huge studies on near infrared helping with infections. Like when you start to just look at the research, there's so much studies on near infrared. There's studies on it healing disc disease. That there was a neurosurgeon in St. Paul that got laser and near infrared to help resolve almost all the disc disease that he saw. Probably 90% of what he would have sent to surgery, he didn't send to surgery. He treated with laser and near infrared. Other questions?
Do you know who that surgeon is, Dr. Vrchota?
He did retire.
Of course.
He did retire. But yeah, Gail, I can get there is training in Toronto that teaches people how to use laser for disc disease, and I'm sure there's people in the Twin Cities that are trained. Chris Foley was.
Yeah.
And someone asked, so red light is something different from near or far infrared. So red light therapy and infrared therapy are different modalities.
Well, the color red is a broad spectrum. I don't know the numbers, but it's something like 600 to 1100, and 660 is the one that resonates with the mitochondria that turns on an enzyme in the bilayer, the two layers that are outside the mitochondria, and helps everything that's supposed to go on happen at an accelerated pace. And 980 is the one that helps warm things up, but red by itself would be like all of those things. So it's not as specific as what's called near infrared or far infrared. Those would be just like a little piece of the spectrum. We've got a little pause here. Does anybody want to talk about melatonin? Melatonin is another thing that can be used with methylene blue and disulfiram. Melatonin is low in people with sepsis, and melatonin at high doses, 120 milligrams, has been shown to improve the outcome of sepsis in people in the ICU. We usually think of melatonin as being in 1 to 3 milligrams. But certainly when I had colon cancer in 2007, the oncologist that I referred to said 60 milligrams a night is going to help reduce your risk of colon cancer more than anything. When I went to the integrative oncology meeting, doctors there were using 60 to 120 milligrams. On the webinar with the chiropractor and with Scott Forsgren on the Better Health Guy, they're often using 120 milligrams, which would make me so sleepy I couldn't function. But they said get out in the sun, and that makes it better, which is fine if it's not 30 below. But you know, sometimes like January, what do we have? 2 sunny days. Getting out in the sun is a little bit hard. But melatonin is available in 60 milligrams in liposomal formulas, commonly available. So if you are thinking about that, just go and look up the volumes of literature of the conditions that are being treated with melatonin.
Yeah, and it's actually one of the things that is recommended as part of the FLCCC COVID treatment, the acute COVID protocols.
Right? There was a dose found between 60 and 120 milligrams. Bye-bye. We'll turn it off. Thanks, Anna. We'll turn
Can
off
you see the record button from your spot?
Yep.
Yep.
Okay, great. See you next week, everyone. Thank you.
Thanks, Anna. What were you saying, Laurie, about melatonin?
Oh, just that it's part of the protocol for acute COVID.
Yes. Yes. In a higher
And-
dose.
Yeah. And someone also mentioned the book Red Light Therapy by Ari Whitten, researched lights and how to use them. So, yeah. Oh, and somebody says, why do they tell me not to take melatonin for long times? I think that the idea is, you know, that your body will then stop making melatonin the way that, you know, that it naturally would. I mean, I wouldn't take 60 milligrams and then just stop. I would taper down. But I think you're using melatonin like almost as a drug, not as a neurotransmitter when you're taking it at super high doses.
Right. It helps the immune system to function better. It helps your sleep to go deeper and become more restorative. So it helps pick up your energy during the day. I think it's still taking something. So if I believe what Thich Nhat Hanh said, the way out is in, I'm taking less and less stuff. I'm on $300 less stuff in February than I was on in December. Like every month that I go through the treatments that we're talking about in this series, the gemotherapy, and next week we're going to have Isabel Frankel talk about human detox therapy. Every month I go through that, I need less and less stuff. So I thought, oh, melatonin, I forgot about that. I should start taking that high dose again. And I thought, well, I want to see what this stuff does first. So there's lots. I mean, I can't believe how many research articles there are. And that our bodies are self-healing systems, even surgery. What we learned on the first day of medical school, that surgeons don't sew you together, that they approximate the edges and your body heals itself. And so we have to remember that our bodies are self-healing systems. And if we get out of the way in whatever way that our lifestyle is in the way, that a lot of times deep healing can happen.
So there's another question. Can you talk about what to do if we get a fresh tick bite?
Why don't you take that one, Laurie?
Okay. So what I tell people to do is to go to my website, which is drradovsky.com, download the handout, which is treatment of tick bites and acute Lyme disease. Take that to your clinician or to urgent care and see if they will treat you according to that. It basically says that we need, well, depends on how many symptoms you have. If all you have is a tick bite, don't throw the tick away, get the tick sent off, because if the tick comes back showing no infection, then you don't need to take antibiotics. But I recommend tick bite with no symptoms, take antibiotics until you know if the tick is infected with anything. And if it is, take antibiotics for 3 weeks. If you have an EM rash, then I would say 3 weeks at least of antibiotics. If you have any systemic symptoms, you know, if you have a EM rash and joint pain or fever or headache, you probably need to be on antibiotics for 4 to 6 weeks. Now, most of the time in that kind of situation, people will get better. They probably don't clear the Lyme, but it goes into a dormant state that will hopefully stay there. And it's that subset of people, that 10 or 20%, who end up with what we call persistent Lyme or disseminated Lyme or chronic Lyme, that are going to need more aggressive care. But, you know, the way to prevent chronic Lyme disease is to treat acute Lyme disease aggressively. And I don't see that happening in a lot of, especially in the Twin Cities. If you go up north, I think the ERs and the urgent cares are much more aggressive with treating and saying, this looks like Lyme disease, we're going to treat. But it is really important to be treated.
And if you go to the emergency room in Winona with the erythema migrans rash, they'll give you 2 doses of doxycycline.
Yeah.
Which is not recommended by anybody, but that doctors have been told that antibiotics are dangerous and to avoid overdiagnosing or overtreating any bacterial illnesses. And they are afraid to use the tools they have. So,
and there's actually even some data that taking, you know, the prophylactic, you know, 200 milligrams will reduce the likelihood that your test looks positive, you know, so it doesn't reduce the likelihood of getting sick, but it reduces the likelihood of a positive test.
It reduces your risk of getting diagnosed properly.
Right, exactly. And somebody mentioned ticks are out and about now. I think it's super important to know that anytime it's above freezing, which it is, ticks can be active. You know, so if you say it's February and I think I just got Lyme disease this year, that's entirely possible.
I've gotten Lyme every month except for February, but you know, there's still time.
Well, this year, you know, you could make it like the sweep. God forbid.
I had a cat that caught mice, and the ticks would go on the ticks would go from the mice onto the cat, and then the cat would come on the sofa, and I was getting bit from the ticks that my cat carried in. So having pets that go outdoors is a way that ticks come in the winter.
And it is quite real. I've gotten about 4 or 5 calls just in the past couple of weeks with people getting bit and having acute symptoms. So, and that's in Minneapolis, St. Paul, along the river there. So,
and I just want to give a couple of examples of neighbors that have called me and said, I think I might have Lyme disease. I went to the doctor. They put me on cefuroxime because I'm a gardener. I wanted to be out in the sunshine. And I went over to see them and their legs were covered with bruise marks. So sent her in and her platelets had crashed. She had Ehrlichia and she needed doxycycline. She didn't want to take it because she wanted to garden, but you know, it could be life-threatening. And the other thing that we've had commonly in our valley is sudden onset fever, chills, and sweats. And that's Babesia until proven otherwise. And so if you think it's Lyme and you got treated for Lyme and it's not working, somebody has to think of Babesia.
Yeah. The other thing is you can use minocycline in the summer and not have to worry about the risk of phototoxicity.
Great. Same dosages, Laurie?
Yeah, the 100 milligrams twice a day.
Great. Any other questions? I think we'll call this to an end. And if you want to, you can turn on your video and turn on your speaker so that you can say hello and goodbye to the group.
Mm-hmm. Yeah. Oh, somebody just asked about spelling that, which I think is minocycline, MINOCYCLINE. So it's like doxycycline is a cousin. It actually has better brain penetration, we think, and is less likely to cause the phototoxicity.
Great.
Can I throw out one last question before we all go away?
Yeah.
Yes.
Okay. You talked a little bit about treatment for long haul. How often do you see negative tests, but people are still respond to treatment? I mean, are the tests accurate enough that that's likely not the case, or are the tests just not accurate for longer Babesia, Bartonella, Lyme infections? Thoughts?
Oh, yeah, no, the challenge with the testing is very insensitive. If it's positive, you can believe it. If it's negative, it's often false negative, because Lyme in particular has so many ways of evading detection. It changes the outer surface proteins, so like if you think of the antibodies as being like a wanted poster, like this is what the organism that we're fighting is like, it can be changing its appearance so that your antibodies never have a chance to create like a good picture of what it is they're fighting. It can also, hide it. It suppresses your immune system so that your body's unable to create the level of antibodies that it needs. So if somebody has a story that clinically is very much likely to be Lyme disease, they've ruled out all of the other things that it could be, then I think it's very reasonable to say, let's do a trial of antibiotics. Let's see, if we give you antibiotics for a month, do you feel any better? And if you do, then we're on the right track. And if not, then maybe it wasn't Lyme disease. But the tests are excruciatingly inaccurate, unfortunately.
And a lot of times after you take a course of antibiotics, your test will come out positive.
Mm-hmm. Yeah. And then somebody is asking, do you have a list of providers you could recommend for extremely complex cases? There aren't that many people that are doing that. Dr. Soleil Arrieta took over your practice, Karen. Tim Montag is somebody that I trained in Alexandria. Asani Stoddard is somebody that I trained who is.
I think we don't say their names on the recorded video. But Mick, Gail and Mick are people that are willing to take calls and help match providers with people, right?
Mhm,
And
yep.
Anne, are you still you in that group?
Yep.
So I think this organization is very helpful in helping people, get matched to somebody that would be somebody that would be perhaps close to what they need.
Definitely.
All right. Thanks everyone for being here. Thank you, Dr. Radovsky.
Thanks.
I'm really glad you're here. Thanks for
Thank
having
you. Thank you
Bye, everyone. Thanks.
Thank you
Good
so
to see you,
much.
Gail and Joan.
so much. Thank you so much.
Kurt, bye-bye.
Bye. Take care.